All right, so welcome to week 7. So for this week, we have 4 chapters. Chapter 5 is the economics of the U.S. healthcare delivery. Chapter 11 is disease prevention or infectious disease prevention and control. Chapter 12 is communicable and infectious disease risks. And then we have chapter 27, which is violence and human abuse. So we'll start with chapter 5, economics of the U.S. healthcare delivery. So we look at the healthcare system within the United States. Healthcare disparities, those are differences among population groups in the availability, the accessibility, and the quality of healthcare services aimed at prevention, treatment, and management of diseases and their complications, including screening, diagnostic, treatment, management, and rehab services. So most of our healthcare disparities we see in those that have lower socioeconomic statuses, race, culture, language differences, sexual identity, and in some cases even gender. And so how healthcare is financed and delivered is going to have a direct effect on the ability of everyone in the United States to obtain timely, appropriate care that is affordable. And so as we recognize those social determinants of health, along with health behavior, that plays a role in the health of individuals and families. So there is strong evidence to suggest that poverty can be directly related to poor health outcomes, which those poor health outcomes will lead to reduced educational outcomes for kids, poor nutrition, low productivity in the adult workforce, as well as unstable economic growth. So we are looking for ways, right, to improve living standards for all members of a population. So to address those healthcare disparities, we did have the Patient Protection and the Affordable Care Act, as well as the Prevention and Public Health Fund, to try to address those. And so, yes, the United States does spend more money on healthcare than any other nation. And so as we look to, work with the communities, it is really important that we understand how health economics works. So what are some of the consequences of, not having health insurance? You think about your levels of prevention, um, the not getting, if you don't have health insurance, they are less likely to do their preventative visits, to get that early screening done, to even get treatment for some of those chronic diseases, which then could have poor outcomes for those disease processes. So we look at economics. Economics it's a science. It's concerned with the use of resources, including the production, distribution, and consumption of goods and services. So when we separate that down into health economics, that's concerned with how scarce resources affect the healthcare industry. And then public health economics focuses on the producing, the distribution, and the consumption of goods and services as related to public health. And so economics does serve to, or provides the means to evaluate the attaining of society wants and needs in relation to limited resources. And so, it just makes that day-to-day decision. The goal of public health finance is to support population-focused preventative health services. And there are 4 principles under public health, preventative health. The source and use of monies are controlled solely by the government. the government does control the majority, but then we have the private sector that controls how the money is used. Services at the federal government level, policy making, which we've talked about, public health protection, collecting and sharing information about the U.S. health care and delivery systems, building capacity for public or population health, direct care services. And then at the state level, we have things like environmental health monitoring, population health planning, disaster management, preventing those communicable and infectious diseases, as well as some direct care services that are provided. So what are some of the factors that affect resource allocation in healthcare? The uninsured. The uninsured, although we did try to make some significant efforts with the Affordable Care Act, we do still have a number of people that are uninsured. Which, like I said, the Affordable Care Act has made a tremendous impact on that. Poor Americans with an income below the poverty level have a mortality rate several times greater than that of middle income Americans. So historically, the link between poor health and socioeconomic status resulted from poor housing, malnutrition, inadequate sanitation, as well as hazardous outcomes. And there, other things, the effects of, characteristics that explain the concept of poverty, low education levels, unemployment or low occupational status, low wages, being a child or a person older than 65, or being a member of a minority group, mental illness also. Is a risk factor. Mentally ill die 15 to 30 years earlier than those that do not have mental illness. So we get down into the access to healthcare or access to healthcare. So Medicaid is intended to improve access to healthcare for the poor. The prime, we look at they may still have some difficulty, but Medicaid does cover pregnant women and children, which does, help to reduce teen mortality, reduce disability, fewer emergency room and hospital visits. And so Medicaid does, it provides healthcare for coverage for individuals of low socioeconomic status and children. Eligibility is based on household size and income, with priority given to children, pregnant women, and those who have a disability. And Medicaid does cover inpatient and outpatient hospital care, labs, radiology services, home health care, vaccines, family planning, the pregnancy-related care, as well as early and periodic screening, diagnosis and treatment services, as well. The issue with Medicaid, reimbursement for services is low, so physicians are, less inclined to serve that population. So that is something that, has become an issue, and it's an issue with Medicare as well. So when we look at the levels of prevention related to economy, primary prevention, behavior and lifestyle have been shown to have the greatest effect on longevity, with the environment and biologic accounting for the greatest effect on the development of all diseases. So we do need to really look at what we're doing for levels of prevention. Higher values should be placed on primary prevention. And so think of some of the things that we do as nurses to work with those, less fortunate. When we look at economic prevention strategies, level prevention, so primary prevention, could be working with legislators and insurance companies to support Affordable Care Act coverage for health promotion services that will help to reduce the risk of disease. Our secondary prevention encourage clients who are pregnant to participate in prenatal care, the WIC program that helps to increase the number of healthy babies, reduce the costs related to preterm baby care and pregnancy complications. And then tertiary, participating in home visits to moms who are at risk for neglecting or abusing babies to reduce the costs related to abuse and neglect by providing guidance and education on newborn and postpartum care. We look at healthy people 2030. The objectives related to access to healthcare services, increase the proportion of adults who get recommended evidence-based preventative healthcare, increase the number of community organizations that provide prevention services, increase the use of telehealth to improve access to health services, and then reduce the proportion of people younger than 65 who are underinsured. So we look at the U.S. healthcare system historically. It's had developed in 4 phases. We have the pre-industrial era, the post-industrial era, the corporate era. And now we're looking towards what's going to happen in the future. So some of the challenges for the 21st century, we do have the emergence of new as well, or I'm sorry, the emergence of new as well as the reemergence of old communicable infectious diseases are occurring, as well as larger foodborne illness or foodborne disease outbreaks and acts of terrorism. 7 out of 10 deaths in the United States are related to chronic disease. So what can we do to help, what's the word I'm looking for? Help to decrease those things. When we look at chronic disease, the chronic disease burden is concentrated among the poor. Poor people are more vulnerable for several reasons, right? Including increased exposure to risk, decreased access to health services. Chronic diseases can cause poverty in individuals and families and draw them into a downward spiral of worsening disease and poverty. If you look at the healthcare costs of some of the chronic diseases, a lot of people, especially those that are underserved or underemployed, or and even your elderly, maybe on fixed incomes, they may not be able to afford their medications, often have to make decisions regarding, whether or not to put food on their table or to buy their medications, those kinds of things. And so really we have to look at, how are we serving? Public health nurses are more involved with population-centered care, so assessment of community needs and the development or implementation of programs to meet the needs of certain populations. So, providing more care in the home, the new moms and babies who are defined at risks, also looking at other areas of public health that we can, assess and provide interventions for. When we look at trends in healthcare spending, we have to look at past as well as present spending. Past decisions reflect, the values and beliefs held by society and policymakers. And then if you look back at 2018, the largest proportion of healthcare expenses were for hospital care and physician services. And so there's a nice chart in your book that kind of outlines what our healthcare spending has been historically. When we look at demographics affecting healthcare age, a major demographic change is, going to occur. then, we do have some population changes that are affected by illnesses like AIDS and chemical dependency. So we look at, by 2060, the year 2060, those older than 65 are estimated to comprise 25% of the population. And so that's how we look, when we look at those baby boomers getting ready to age. The baby boomers were the largest generation that we had historically. And so they are going to, just think of the population of the elderly or the dynamics of the elderly, right? As we get older, we're more prone to multiple diseases, as well as degenerative conditions that can become disabling. And so they are going to take up, they are going to take up a lot of our healthcare services. Life expectancy is an average of 78.9 years. Um, and as we look at, the changes that have occurred in healthcare, our life expectancy is actually increasing. Um, and so we do have to, take that into consideration. When we look at ethnicity and health disparities, ethnicity shows health disparities fuel some of the costs of healthcare in persons who are racially, ethnically, linguistically, or gender nonconforming. They tend to have worse health outcomes. Um, we look at technology and intensity. The introduction of technology enhances the delivery of care, but it's also really expensive, right? So as new and more complex technology is introduced into the system, the costs are typically high. Um, and so, I don't know how many have dealt with insurance companies with things. Um, but I'll just use medications as an example, right? So we all look at all have watched TV, we have heard the um commercials or, for the new drugs and the new testings and all of those things. New drugs are generally more expensive than previously released medications. And when we look at advertising, of course, if they have that disease, they want to try something that's new and better, even if the medication that they are currently taking is working. What they don't understand is often people don't understand is that those medications are not usually first line treatments yet, and they're not going to be covered at the same rate as their other medications when it comes to their insurance. Um, and so, you know, maybe the drug is newer and it is better. Um, but it may not be affordable. Once they start, once the medications are on the market for a while, generally, or if they have a generic that becomes available, that is generally when the medication prices will drop. But that is, technology is a wonderful thing. However, it can also be very expensive. When we look at chronic illness, chronic diseases account for about 70% of deaths in the United States, as well as, the majority of our healthcare spending. And so, it is a huge part of our healthcare system. We look at financing of healthcare. So we do have the Medicare and the Medicaid programs. Again, Medicare is for individuals older than 65 that are receiving Social Security or have been receiving disability benefits, have ALS or disability benefits, kidney failures. There's different parts to Medicare. You have Part A that covers your hospital care, your home care, your hospice, some limited nursing or skilled nursing care. Part B, and Part A is the one that um, is paid for through your taxes. There's that money that comes out of your paycheck. Part B covers your medically necessary So your healthcare provider services, your outpatient care, your home health, your diagnostic, your physiotherapy, your DME, ambulance services, mental health, preventative services, that kind of thing. Um, Part B is something is supplemental. It's not mandatory. So like if you hit 65 and you sign up for Medicare, you automatically get Medicare A, but Medicare B is something additional that has to be paid for. Um, it also can cover, and so that is something that people have to take into consideration, because that is extra out of pocket costs. And we have Part C. Part C with Medicare, that's your Medicare Advantage plans. Those are, the ones that you see on TV, like the supplemental insurances, that you can get through a private insurance company. And then, of course, Part D is your prescription medication coverage. Um, those are all outside of the traditional Medicare. Um, and then we have our Medicaid, which we did talk about, that provides the healthcare coverage for those of low socioeconomic status and children, um, the blind, the disabled. It is jointly sponsored and financed with matching funds from federal as well as state governments. Some mandatory services for Medicaid are your early periodic screening, diagnosis, and treatment services, your inpatient, outpatient hospital care, lab and radiological services, um, skilled nursing either at home or in a nursing home. And in some cases, other services that can be offered through Medicaid would be your rural and federally qualified health services, your freestanding birth centers, tobacco cessation counseling for pregnant women, transportation to medical care. So it really just kinds of, depends on, what you have. When we look at the Affordable Care Act, Prevention and Public Health Fund, that the Public Health Fund, they put more of an emphasis on chronic disease. Um, and so funds are allocated to states to implement those provisions. And so there is a chart in your textbook, which kind of outlines that for you. Then we have our private support. Um, those are private healthcare payer services like that include insurance, employers, managed care, and other individuals. Um, Sorry. So when we look at, you have insurance that is often provided through your employer based on, where you work and what they offer. Most of them are through like, private healthcare system, insurance companies like United Healthcare, Blue Cross Blue Shield, Aetna, those kinds of things. Um, and so it really just depends on where you're working and what your employer is offering. Some employers pay more towards your premiums. Others pay less. It really just kind of depends on the size of the company as well. Um, when we look at healthcare payment, we look at the private payment systems. We have different types of paying healthcare organizations. So retrospective reimbursement is that more traditional fees for the delivery of healthcare services are set after services are delivered. So you go into the doctor, you get your physical, you get whatever you want. Um, and then, they bill the insurance company. Whereas prospective reimbursement, that is the payer establishes amount of money that will pay for certain services. So for example, that same physical, so maybe with retrospective, the physical is $400, and they'll bill your insurance, and then your insurance will pay a certain part, and you may have to pay a certain part. With prospective reimbursement, there's already a contract in place that says, okay, if you are going to provide for this person to have their physical, this is what we're going to pay you. And so that's a lot of times too, when there's certain things that need to be done. I'm sure some of some of you have heard of like getting prior authorization, right? If they're under the prospective reimbursement, if you need to have a procedure, surgery, or even something different, certain medications, certain testing, your provider has to send in a prior authorization request, to get approval prior to performing the test. And so when we look at, what's in the future, this is where we need to be aware of, exactly what's going on, within the healthcare industry so that we can kind of prepare for that. Um, we need to know what the, cost of nursing services, where can we make, cost savings, how is nursing care, practice affects and is affected by, what the principles, of economics are. Anywhere that you work within healthcare, there's always looking for different ways to try to provide the same quality of care as well as, cutting costs at the same time. We look at other nursing interventions. We also want to do that community assessment that helps us to identify barriers to adequate health care. Want to maintain our awareness of healthcare standards, use of healthcare resources, understand the partnership and communication between local, state, and federal health services. We want to also try to um, assist individuals and groups, in getting adequate access to healthcare, as well as to promote equity in our healthcare delivery systems, as well as, again, maintaining that knowledge and skills related to the economic principles. So when we're providing care, or even budgeting for care. All right, that brings us to chapter 11. Chapter 11 is infectious disease prevention and control. So, back in 1900, communicable diseases were the leading cause of death in the United States. And so with the improvement in sanitation, nutrition, and, we discovered antibiotics as well as vaccines. That has ended some of the epidemics like your diphtheria, your typhoid. It's reduced other, diseases as well. And so we do still have some new ones that are out there. Hmm. Um, we've had outbreaks, and there's other diseases as well. The flesh eating bacteria, mad cow disease, your Spanish flu, your COVID, Zika virus. We also have like the more antibiotic resistant, right? Bacterias, right? It's your MRSA, your VRSA, Ebola. I'm trying to think of some West Nile virus. So there's other up and coming. SARS was another one, the severe acute respiratory syndrome, that was, out in like the Asian countries, China, Vietnam. And so they're, think about it, we get rid of one, sometimes we end up with another one. Infectious disease or communicable diseases are a worldwide concern. The more people move around, right, from, just whether vacationing or even immigrating, they often can bring, diseases from one area to another, even if those diseases are not indigenous to that area. About that. We also have to worry about bioterrorism. Infectious disease is a result of bioterrorism. And if you remember 2000, the 9/11, anthrax became, we knew that it was always out there and it was always a possibility. We had, the people mailing anthrax. It is a concern that we do worry about. Anthrax, of course, is not the only one that is out there, but infectious disease is also one of those things that we worry about with bioterrorism. So when we look at the transmission of communicable diseases, remember it's the epidemiological triangle. Your agent factors. We look at the agent factors, the infectivity, the pathogenicity, the virulence, the toxicity, invasiveness, antigenicity. So infectivity is the ability to enter and multiply in the host, right? So whatever the infectious agent gets, gets into the host, and the ability to enter and then grow within that host. Your pathogenicity is the ability to produce a specific clinical reaction after the infection occurs. So once the pathogen gets into the body, how able is it to cause an infection? Virulence is the ability to produce a severe pathologic reaction. Toxicity is the ability to produce a poisonous reaction. Invasiveness is the ability to penetrate and spread throughout tissue. And antigenicity is the ability to stimulate an immunologic response. So we look at host factors. This is like resistance, your types of immunity, your infectiousness. So resistance is the ability of the host to withstand infection. And it can involve either your natural or your acquired immunity. So your natural immunity, that's your innate resistance to an agent, right? Your acquired immunity is resistance as a result of a previous exposure, right? So kids that have had chicken pox, they've had chicken pox, generally speaking, in most cases. The body recognizes it and we don't get infected with chicken pox again. Active immunization, that's, where we give them either, a vaccine or an immunization, whereas then, we develop that antibodies to whatever that disease is, so that if we are exposed to it, we attack it right away. Vaccinated children against childhood diseases, that's, one way that we get active immunity. Your passive immunization, that's the transfer of specific antibodies from an immune individual to a non-immunized, or from an immunized individual to a non-immunized individual. And then, that unfortunately, the passive immunity is almost immediate, but it's very short-lived. Herd immunity. Herd immunity is protection due to the immunity of most community members, making exposure unlikely, right? So everybody else gets their, their immunizations, you may have a few that don't, so they rely on herd immunity to not get sick. And then infectiousness is the measure of the ability of an infected host to transmit the infections to others. So, you know, how does the infections transmit from one person to another? Is it airborne? Is it droplet? Is it contact? Is it through food? Whichever. And then when we look at the environmental factors, that's the physical, the biologic, the social and cultural factors that are part of the human host. Those are the factors that enable the transmission of an infectious agent from a host to other susceptible hosts. And so, what are some of the ways that, we can look at that environment to prevent the transmission from one to another? So we look at modes of transmission. Infectious disease can be transmitted horizontally or vertically. So your vertical transmission, that is something that's an infection is passed from parent to offspring via via sperm, placenta, milk, or contact in the vaginal canal at birth, right? So like your HIV, herpes, things like that. Your horizontal transmission is person to person spread of infection through one or more of the four routes. So direct or indirect contact, a common vehicle, airborne or vector-borne. So it's like your STDs or your STIs, bed bugs. A common vehicle is the transportation of the infectious agent from an infected host to a susceptible host via food, water, milk, blood, serum, saliva, or plasma, like your tuberculosis, your hepatitis B, what else? Legionellosis. And then vectors, those are arthropods like your ticks and mosquitoes that can transmit infectious disease by biting or depositing infected material near the host. When we look at disease development, infection is the entry, the development, the multiplication of the agent within the host. And then disease is one of the possible outcomes of the infection. And that could either be a physiologic dysfunction or a pathologic reaction that occurs. The incubation period is the time between, that you were infected and the first appearance of signs and symptoms. And our incubation periods for different diseases is going to vary. It just really depends on whatever the disease is. The communicable period, that's, when we get the that is the time where the infectious agent can be transferred directly or indirectly from an infected person to another person, right? So how long are you contagious for? And again, depending on what disease we're talking about, that is going to determine how communicable that disease is and how fast it can be, how it can be spread. We look at the disease spectrum, we look at endemic, epidemic, or pandemic. So endemic is the constant presence of a disease within an area or a population. So according to your textbook, like pertussis is endemic in the United States. An epidemic is the occurrence of a disease in a community or region in excess of normal expectancy. So, right, we may have a certain amount in one area, but all of a sudden we have an increase in numbers. That would be something that would be epidemic. So the book uses polio. So one case of polio would be considered epidemic in our area, or in our country. So polio was originally eradicated because of the use of the polio vaccine. So if we had one case, that would be concerning. And then pandemic is an epidemic that occurs worldwide. It affects large populations, right? So everybody knows about COVID. We know that that was one that spread very rapidly worldwide. Um, so when we look at surveillance of communicable diseases, um, this is the who, when, where, why. Um, or I'm sorry, the who, when, where, and what, and then we use those to answer the question why. Um, Good surveillance collects, organizes, analyzes current, accurate, and complete data for a defined disease condition. And then we get that information, and then we can, provide that or develop that effective planning, implementation, and evaluation for disease prevention and control programs. So some of the basic elements of surveillance would be mortality registration, morbidity reporting, epidemic reporting, lab reporting, individual case investigation, surveys, the use of biologic agents and drugs, distribution of animal reservoirs and vectors, demographic and environmental data. When we look at the list of reportable diseases, it does vary by state, and so you can go to the CDC provides a list, but you can go to your state health departments, and that will give you a list of reportable diseases. So like most of your STIs, your HIV, your tuberculosis, salmonella is reportable as well. It's just really important to know in your areas what is a reportable disease, so that if you do, if you're working in the emergency room, you're working in a clinic, whatever it is, that you're reporting those diseases so they can do follow-ups. Emerging infectious diseases, those are diseases where the incidence has increased in the past several decades or has a potential to increase in the near future. And they may be new or even known infectious diseases. So Ebola, your West Nile virus, your COVID-19, um, other emergence factors, um, factors that can influence the emergence of new infectious diseases, social events, social societal events, wars, conflicts, even population growth and migration. With healthcare, the new medical devices, organ tissue transplants, drugs that cause immunosuppression, overuse or widespread use of antibiotics, food production, the changes in food processing and packaging, the globalization of food supplies. The United States have one of the more stringent control over food packaging production through the FDA. Which is why we, even with some of our medications and things like that, we don't usually accept from overseas just because we have more stringent practices here in the United States. Human behavior, sexual behavior, drug use, travel, diet, outdoor recreation, childcare facilities, right? We all know sending our children to daycare, that's where all those wonderful germs are spread. Um, environment, either the deforestation or reforestation, changes in our water ecosystems, floods, droughts, famines, those global changes. Like we talked about global warming, public health, reduction in preventative programs, inadequate disease surveillance, a lack of trained professionals like your epidemiologists, your rodent control specialists, and microbial adaptation, changes in the virulence and toxic production, the development of drug resistance, right? We know that that has made some tremendous impact on how we treat disease and the medications that we have that are available. Some of the other, emerging infectious diseases, the like Lyme disease, um, E. coli, HIV, HPV, your influenza viruses, your SARS, your West Nile virus. Those are all some things that we need to pay attention to. And so when we look at prevention of communicable diseases, of course, we have our levels of prevention. So primary prevention seeks to reduce the incidence of disease by preventing it before it happens. So some of our primary prevention measures, prevent the occurrence of infectious disease. We can educate the public regarding the need for immunizations, as well as looking at those federal and state immunization programs. We know that patients or people are going to travel to other countries. We do also have to educate them about protecting themselves. And so like going to the World Health Organization website, CDC, you can look at maybe possible immunizations that you may need to have before you travel to other countries. We can also educate the public regarding prevention of disease as well as ways to eliminate their risk factors for exposure, right? We know about hand washing, our universal precautions, proper food handling and storage, use of insecticides, use of condoms, to prevent those STDs or STIs. Your secondary prevention, we know, aims to prevent the spread of disease once it occurs. So things like early detection through screening and case finding, referring suspected cases of communicable disease for, test confirmation, as well as epidemiologic reporting, providing post-exposure prophylaxis, right? Like your hepatitis A, your rabies, your HIV, quarantine client patients when necessary, using partner notification and contract tracing to identify and screen individuals have been exposed to a communicable disease. And then we know tertiary prevention works to reduce complications and disabilities through treatment and rehab. So that also, we're looking to decrease complications and disabilities due to those infectious diseases, monitor treatment compliance. So like your tuberculosis, right? Tuberculosis is one where we may have to use directly observed therapy or your DOT therapy. For those that we suspect may become non-compliant with their care. So they go to the clinic every morning to get their medications, as well as identifying and link clients to any of those, community resources that they may need. So agents of bioterrorism. And so when we look at agents of bioterrorism, there is, enough out there that we do worry about, that are, potential issues. And so, excuse me, anthrax, which is your Bacillus anthracis, the symptoms appear within 7 days of coming in contact. Treatment for a person who is exposed but not yet sick generally is an antibiotic. Cipro is one of the more common ones that we use for anthrax. After exposure, it's usually a 60-day course of antibiotics. Success is going to depend on the type of anthrax and how soon treatment begins. Plague is Yersinia pestis. That's, not something that anybody wants. Smallpox is another one. Smallpox has been eradicated. It, can be used as a bioterrorism because susceptibility is 100% in those that are not vaccinated against smallpox. And so if, if somebody got vaccinated before 1982, they are not considered protected. They may have some immunity, but the fatality rate is anywhere from 20 to 40% or higher for smallpox. There is a vaccine that may be protected, even after exposure. We don't give smallpox vaccine to the general public, but there are certain populations that have been, immunized against smallpox. And there is a nice chart in your textbook on how to distinguish chickenpox from smallpox. Tularemia, botulism, some of your selective hemorrhagic viruses are also some diseases that we would, of course, worry about. Then we have our vaccine preventable diseases, and that's your measles, your mumps, your rubella, your chickenpox, pertussis, even influenza is on there. If you do go to the CDC website, the CDC website does give you your immunization schedule. That is the recommended immunization schedule. And so it, like for diphtheria, tetanus, acellular pertussis, your DTAP, that's 5-dose series that we give to infants and children. Your MMR is a 2-dose series. They get the first one at the age of 12 months, and then they get the second dose prior to entering school, usually around 4, 5, 6. Influenza is yearly. And so again, you can go to the CDC website that is going to, you can look to see the immunization schedule for kids. Just trying to and then there was, for some reason, that a child was not able to get their vaccines when they were supposed to. For example, maybe they had an infection at birth or something else was going on, some kind of congenital issue. The CDC also has what's called a makeup schedule. So if they miss any of their immunizations for whatever reason, then there's a schedule that providers can follow in order to catch them up on their immunizations. Foodborne illnesses and waterborne illnesses. Foodborne infections, they can be bacterial, viral, parasitic. Those are things like your norovirus, your salmonellosis, your hepatitis A, your trichinosis, your E. coli. Some of your waterborne diseases like cholera, typhoid fever, dysentery, giardia. Let's see, yeah. And so when we look at the 5 keys to safer food, keep clean, right? Wash your hands before handling food, and then often during food prep, wash your hands after going to the bathroom, wash and sanitize all surfaces and equipment used for food prep. Protect areas from protect areas and food from insects, pests, and other animals. So you have a really good example of this. So I had taken care of a patient. He was 4. He had salmonella. They didn't have, and so they had a exotic pet. I think it was a bearded dragon. And bearded dragons are known to carry salmonella. And the dragon was walking on the counter. And what ended up happening was mom didn't wipe the counter and made her son some food. The salmonella got in the food and caused the child to get sick. So, making sure that the area is clean. Separate raw and cooked. Separate raw meat, poultry, and seafood from other foods. Use separate equipment and utensils like knives, cutting boards for handling raw foods. And then store food in containers to avoid contact between raw and prepared foods. And then cook thoroughly. Cook your food thoroughly, especially meat, poultry, eggs, and seafood. Bring foods like soups and stews to a boiling to make sure they reach, a high temperature. For meat and poultry, make sure that juices are clear, not pink. And then keep food at safe temperatures. Don't leave cooked food at room temperature for more than 2 hours. Refrigerate properly all cooked and perishable foods. Keep food hot before serving. Don't store food too long, even in the refrigerator. Don't thaw frozen food at room temperature. Use safe water and raw materials. Select fresh and wholesome foods. Choose foods processed for safety, like your pasteurized milk. Wash fruits and vegetables, especially if they're eaten raw, and then don't use food beyond its expiration date. And so foodborne illnesses can be either a food infection or food intoxication. So food infections come from your bacteria, your viruses, or your parasites. And then infection of foods, your salmonellosis, your hepatitis A, your trichinosis. The intoxication occurs from toxins that are produced by bacterial growth or chemical contaminants, and then other disease producing substances that are found naturally in certain foods. So some examples of food intoxications like your botulism, your mercury poisoning, staph aureus. So there's a variety. Your waterborne diseases, those are usually the result of fecal contamination of water, which can lead to like cholera, typhoid fever, your dysentery, I already said that, sorry. Okay, then you have your vector-borne. These require a carrier, which is usually a mosquito, a tick, a fly. With biologic transmission, the vector is necessary for the infectious agent to develop. So like mosquitoes that carry Zika virus or malaria, the fleas that transmit plague. Your mechanical transmission occurs when an insect contacts the infectious agent with its legs or mouth parts and then carries it to the host. So flies and cockroaches may contaminate food or even cooking utensils. Some of your vector-borne infections, your West Nile virus, your Lyme disease, your Rocky Mountain spotted fever, rabies, malaria, zoonoses, um, disease of travelers. Individuals traveling outside the US need to be aware of, take precautions against potential diseases that may be exposed to. And so that's why, you can go to the CDC website that will give, you some information regarding where you're going to travel, if you need to have any preventative or prophylactic medications, any immunizations. And so those are always things to kind of look at before you like travel so that you know what to prepare for. You'll also may bring things home that can spread to other people as well. Another big thing that we worry about too is our healthcare associated infections. Those are, infections that are acquired during hospitalization or develop within the hospital setting. And this could be patients, it could be the healthcare workers, visitors, anyone who has contact with the hospital. Problem with these is they're often more virulent, they're often more difficult to treat in some cases as well. And so that's why we use those universal precautions. And we know hand hygiene is key. Healthcare associated infections have a huge impact on the cost of healthcare, especially as the transition has been made from from quantity of care to quality of care. And so oftentimes, hospitals won't get reimbursed for care should they develop a hospital acquired infection while they are there. So especially, looking at your lines, right? Your Foley catheters, your PEG tubes, your IVs, your central lines, whatever type of line that they have, your intubated patients, and then, even in something along the lines of wounds. So in long-term care, we use what we call enhanced precautions. And so anybody that has a tube feeding, an IV, a Foley catheter, a suprapubic catheter, any of those things, we use enhanced precautions. And so even though they are not infectious, um, we will still gown, of course, and glove, when we are, providing care to these patients, just so that we can protect them, um, from us, so that we don't, introduce any bacteria, into, from while we're providing care. And then, of course, you want to make sure that you're providing good care to those lines and areas, to prevent infections. All right, so that brings us to chapter 12. Um, chapter 12 is communicable and infectious diseases. And so risk changes often. These diseases are often acquired through behaviors that can be avoided or changed. So the focus is primarily on disease prevention, whether it's vaccines or late detection, or even, education programs. And then those that live with these chronic infections can also can transmit them to others. So we look at healthy people 2030 objectives or goals, I'm sorry. So we want to reduce the infections of HPV types prevented by vaccine in young adults. It reduced the rates of mother-to-child HIV transmission and increased the proportion of adolescents who get recommended doses of the HPV vaccine. So start with HIV. HIV, we know, has a huge political and social impact on society. New diagnosed disease has grown enormously. It was first recognized in 1981, with the first reports of AIDS. It is highest among our adults ages 25 to 29, and then 20 to 24. It is one of our, greatest public health challenge that we have. Cost for providing care for HIV patients is huge. And so, it is a virus. It attacks the body's immune system. And then if HIV is not treated, it can lead to AIDS. We don't have a cure, but with appropriate and proper medical care, we can control the disease. And there's 3 stages: the primary infection, which occurs within a month of contracting the virus, and then it's followed by a period where there are no symptoms, where that's your clinical latency. And then we have the final stage of symptoms. So when HIV enters the body, it causes a mononucleosis-like syndrome. I don't know if anybody's ever had mono. And that's that primary infection so they have they may have flu-like symptoms, similarly fatigue, and then, might just not even recognize that as anything kind of serious. And so, initially the body's CD4 white blood cell count will drop when the virus is most plentiful. And then the immune system increases antibody production and response, which is self-limiting. So again, they may have flu-like symptoms for the 2 to 4 weeks after infection. And then after 6 weeks to 3 months, the antibodies appear in the blood. And And then during this prolonged incubation period, they have a gradual deterioration in the immune system and then can transmit the virus to other people. Sorry. Um, and so the last stage is your HIV, is your AIDS. And that's the most severe phase. That's when their CD4 cell count drops below 22 cells per cubic millimeter. Or if they develop opportunistic infections. And once they transition to AIDS, there's nothing we can do, nothing that we give them that can help them. So it is transmitted through blood and body fluids. So blood, semen, vaginal secretions, and breast milks. It is not transmitted through casual contact, such as touching or hugging, or insects, coughing, sneezing, office equipment, or sitting next to, or somebody that has HIV. So it's primarily your sexual contact where we have the exchange of body fluids, sharing or reusing needles, syringes, or other equipment that are used to prepare injectable drugs. We have perinatal transmission from an infected mom to her fetus during pregnancy or delivery, or if breastfeeding. And then transfusions or other exposures to HIV, like contaminated blood or blood products, organs, or semen, that kind of thing. Many are unaware that they have HIV. Again, initially, like I said, they have the flu-like symptoms, right? They may just kind of pass that off. Most often it's transmitted through sexual behaviors and needle or syringe use. Oh my goodness. And so it also AIDS disproportionately affects minorities. Things like geographic location, age, ethnic distribution are tracked to more effective target programs. So those are the ones that we need to, really focus our education on. African Americans have the largest HIV disease burden of any other racial or ethnic group in the US. African American rates of new HIV infection are 8 times higher than in whites. And so we really need to focus our attention on providing education. Those are your higher risks, again, minorities, male to male sexual contact, as well as your transgendered women. So testing for HIV, the HIV antibody test is the most commonly used screening tool for determining infection. It doesn't reveal whether an individual has symptomatic AIDS, doesn't isolate the virus, it just indicates the presence of the antibody to HIV. There's also rapid HIV testing that uses oral fluid samples. And you can do that at home. There's self-testing for that. It is about 99.5% accurate. We do recommend routine HIV testing for adults ages 13 to 64 at least once. And of course, if they are high risk, then we suggest that they get tested more often. It is confidential. It is anonymous. And so when we look at caring for clients with AIDS in the community, because it's chronic, right? They are going to live, they're going to work, they're going to participate in, activities within the community. So they also, may have periods where they have illness or periods in which they feel fine. When they are ill, most of the care is going to be provided to them in their homes. So the nurse teaches families and significant others about personal care and hygiene, medication administration, standard precautions to ensure infection control, healthy lifestyle behaviors, right? Adequate rest, nice, good nutrition, exercise, making sure that they, adhere to their medication regimen, because we all know you got to take your medications appropriately in order for them to be effective. And so when we look at the Americans Disabilities Act. And there's other laws that protect people with HIV and AIDS against discrimination in housing, work, and other public situations. So nurses can rely on these policies to provide direction for the community's response when somebody does get HIV. So identifying resources such as social and financial support services, implementing school and work policies, assisting employers by educating managers about how to deal with or how to deal with ill or infected workers to reduce the risk of breaching confidentiality or wrongful action such as termination. We also need to look like our HIV infected children should still attend school because the benefits of attendance outweigh the risks for transmitting or acquiring infections. We do have a number of growing services that are available for people that have HIV and AIDS. There's voluntary and faith-based programs that may provide counseling, support groups, legal aid, personal care services, housing programs, community education programs. So we work with those people in the community. They can be in the client's homes as well. And then with methods to prevent and treat HIV, we do have pre-exposure prophylaxis or your PrEP. That is a new HIV prevention method, and I'm sure people might have heard, heard the commercials on the radio or seen the commercials on TV. It is a daily pill to prevent HIV virus from getting into the body, and it's effective. It has been shown to be effective for people that are at high risk for HIV through either sex or IV drug use. It shows that the studies have shown that PrEP reduces the risk of getting HIV from sex by about 99% if it's taken daily. And then 74% for those who inject drugs. And we look at ART or your antiviral or antiretroviral therapy. Those are medications that slow the progression of the virus in the disease. And so it's usually it's a combination of medications, which is your heart therapy. The drugs reduce the amount of the virus in the person's blood and body fluids. It also reduces the chance of transmitting HIV to others if they take the medication correctly. Then we have our sexually transmitted diseases, your gonorrhea, your syphilis, your chlamydia, your herpes, your HPV. Sexually transmitted diseases are a major public health challenge, major public health challenge in the U.S. The numbers of new cases of gonorrhea, herpes, HPV, and chlamydia continue to increase. Chlamydia is the most commonly reported infectious disease. Gonorrhea is the second most common. So we'll start with gonorrhea. Gonorrhea has an incubation period of 1 to 14 days. It can be a little bit longer. Males will have urethritis. They will have a purulent discharge, painful urination, epididymitis. Women usually don't have any symptoms, or they could have symptoms of pelvic inflammatory diseases. And so treatment is usually antibiotic, something like ceftriaxone. We also need to get their partner history for the past 60 days. And so we need to not only treat the person, but we need to treat their partners. And both the client and the partner should abstain from sex until the treatment is complete. Syphilis has a much longer incubation period. It can be anywhere from 10 to 90 days. Average is about 3 weeks. Stages are generally diagnosed by the appearance of hallmark symptoms. So your primary symptoms, they will usually have like a painless canker. And if it's untreated, it will heal in a few weeks. With secondary, they have a low-grade fever, malaise, sore throat, headache. They will have enlargement of lymph nodes as well as a rash. And then in your latency, sorry, in your latency stages, early latency, they're usually asymptomatic. They may have an infectious lesion that can occur. In your late latency, they are also asymptomatic and non-infectious, except to a fetus of a pregnant woman. Um, and, depending on how far, it goes, it could eventually lead to death if it's left untreated. So treatment for your primary, secondary, or early latent 1 year, it's literally a penicillin shot. Latent, less than a year or of unknown duration, again, it's, your penicillin. And then if they've already had, CNS involvement, cardiovascular involvement, or if, there's children or pregnancy, congenital syphilis, or if the person has a penicillin allergy, then we need to refer to CDC guidelines for counseling. Again, same thing with your syphilis. We need to account for all of their sexual partners. They all need to be tested and treated potentially as well. Chlamydia, don't really know much, it probably about 7 to 14 days for its incubation period. Male may have no symptoms, or they may have some urethritis, painful urination. They may have a discharge as well as epididymitis. Women may have no symptoms as well, or they may have some purulent cervicitis, vaginal discharge. If it's left untreated in women, it can progress to the symptoms of pelvic inflammatory disease. Antibiotics, again, is a drug of choice to treat chlamydia. We also need to get their past partners, get them tested, potentially treated, and then encourage abstinence of sex until everybody has been treated. And then we have our herpes simplex virus. Herpes simplex virus, there's two types. You have HSV1, HSV2. HSV1 is the one that causes like your cold sores. HSV2 is the one that causes your genital herpes. These are painful vesicles, painful ulcerations of the penis, the vagina, the labia, the perineum or anus. The lesions usually last about 5 to 6 weeks, and they do have recurrence. There is no cure for genital herpes, but we can treat the symptoms. So we can use antiviral medications to prevent or shorten the outbreaks. Partners also need to be evaluated, and lots of patient education, right, about how to treat, how to use the medications, how to avoid transmitting from from you to your partner. And then we have HPV. HPV is genital warts. It's human papillomavirus. Usually there's pretty good range of incubation period. Usually they also may be asymptomatic, but they may have some painless lesions near their vaginal openings, anus, the shaft of the penis, the vagina, the cervix. There is no cure here as well. Some people, the lesions will disappear without any kind of treatment. But the focus for HPV is prevention. And so we do have the Gardasil vaccine. And then, of course, two of the HPV viruses, your 16 and 18, can cause cervical cancer. And so Gardasil is the only approved HPV vaccine that we have available here in the United States. And and then we have hepatitis. So there's hepatitis A, there's hepatitis B, there's hepatitis C. There's actually other types of hepatitis as well, but generally don't see a lot of those here in the United States. But hepatitis A is a vaccine preventable. So there is a hepatitis A vaccine. It's a 2-dose vaccine. The vaccine is recommended for children over the age of 1. Um, and so it's most often, your Hep A is your fecal oral. So it's most often transmitted through fecal oral route. Sources may be water, food, or sexual contact. Um, it's usually a self-limiting disease. It doesn't lead to chronic infection. Kids under 6 generally won't have any symptoms. So it usually goes unrecognized. Older adults and children, adults and older children may have symptoms that last about 2 months, like fever, fatigue, nausea, vomiting, loss of appetite, dark urine, clay-colored stools. And if it's severe, they may require hospitalization. The best way to prevent Hep A is vaccines and good sanitation. Other recommendations for Hep A vaccine would be if you're traveling to a country where Hep A is common, if you are a man who has sex with other men, if you use illegal drugs, you have a chronic liver disease like hepatitis B or C, if you're being treated with clotting factor concentrates, or you work with hepatitis A infected animals or in a research lab, or you expect to have close personal contact with an international adoptee from a country where Hep A is common. Your hepatitis B is spread through blood and body fluids, can survive at room temperature for at least 1 week. And so again, it is spread through blood and body fluids. So we call this a bloodborne pathogen, like we do with HIV. So every year, as part of your nursing career, you will go through bloodborne pathogen training. Mostly focuses on HIV and HPV, which is your hepatitis B. You're more likely as a healthcare provider to get Hep B than you are HIV. And so biggest way to prevent hepatitis B is to get your Hep B infection or your Hep B immunization. The groups with the highest prevalence of HPV are those that are injection drug users, those that have STDs or multiple sex partners, immigrants and refugees and their descendants who came from an area where there's a high rate of HPV, your healthcare workers, those that are on dialysis, as well as inmates of long-term correctional institutes. And so immunization is probably the best thing. And then you have hepatitis C. Hepatitis C is spread through blood or body fluids. It is a bloodborne virus. It's transmitted when blood or body fluids of an infected person enter an uninfected person. So now, today people must get Hep B by sharing needles or other equipment to inject drugs. So your groups at highest risk are your healthcare workers, your emergency personnel who are accidentally exposed, your infants of infected mothers, and your injection drug users. And so primary prevention for hepatitis C is screening of blood products and donor organs and tissues, risk reduction counseling services, getting a history and whether or not they use injection drugs. Let's see. It is the most common chronic bloodborne infection in the US. It's the leading cause of chronic liver disease and stage liver disease, liver cancer, and liver transplants in the United States. And then we have tuberculosis. So tuberculosis is a mycobacterial disease. It's caused by Mycobacterium tuberculosis. Transmission usually occurs through exposure to the bacilli in airborne droplets from somebody with pulmonary tuberculosis who talk, cough, or sneeze. In the lungs, it can cause symptoms like a cough that lasts 3 weeks or more, pain in the chest, coughing up blood or sputum, weakness, fatigue, weight loss, lack of appetite, fever, chills, sweating, or your night sweats. Incubation period for tuberculosis is about 4 to 12 weeks. So it's a very slow growing acid fast bacteria. Um, sorry. And so to prevent TB, the CDC works with public health agencies to improve screening and reporting cases, as well as to improve treatment strategies. And so it's a coordination of efforts. So the most effective tuberculin skin test is the Mantoux test. So we use that purified protein derivative. It's 0.1 mLs. We put a little bleb underneath your skin. We inject the serum, and then 24 to 40 or 48 to 72 hours, you look at that area to see if there is any reaction. We are not looking for redness. We are looking for induration. So we're looking to see if you have like a lump or like an elevated area where we gave that TST. We also have like your TB Gold test. Um, what's the other one? There's the TB Gold, and I think it's a T-spot is another one that we can do. And so again, we're going to do the 0.1 for the Mantoux test. We're going to do 0.1 mLs of the purified protein derivative right underneath the epidermal layer of the skin. So it's transdermally, not transdermally, intradermally. Then we're going to read it 48 to 72 hours. That's when we want to read the results. Again, we're only measuring the induration, and we're going to record it in millimeters. And there's different interpretations. And so if the test, so depending, this is where we're gonna, so if the test is positive, the induration is greater than 5 millimeters, and those that are immunosuppressed, those that have HIV, those that have had previous tuberculosis that was untreated, the close contacts with somebody with tuberculosis, or in our organ transplant patients. Greater than 10, it is positive, and those with certain medical conditions like diabetes, alcoholism, drug abuse, our IV drug users, our foreign-born persons from areas where tuberculosis is common, kids under 4, those that are residents and staff of long-term care facilities, jails, and prison. And then if it's greater than 15 millimeters, it is positive in all persons more than 4 years of age with no risk factors for TB. So there's different guidelines for reading your PPDs. So first thing we're going to do, we'll do that PPD. If it is positive, then we'll do a chest x-ray. Clients with TB should be treated promptly with appropriate combination of medications, right? So it's usually 3 to 4 medications. So isoniazid, rifampin. Oh, what's the other one? It's usually a combination of 3 or 4 medications that we are going to give them. So we do use that combination. There is a risk that we do have multi-drug resistant tuberculosis. And so we need to make sure that they are on the appropriate medications. If we do run the risk there, or we think that they may be non-compliant with their medications, only because treatment for TB is pretty long process, we will do what's directly observed therapy. And so they'll have to go, you know, to a clinic in the morning, take their medications before they can go about their day. So when we look at the levels of prevention, so primary prevention, right, provide community education about prevention of communicable diseases to populations, vaccinate for Hep A or Hep B, provide outreach for education, needle exchanges, safe drug use, or safe sex, that kind of thing. With our secondary prevention, that would be like giving somebody a PP or performing a PPD, testing, counseling for HIV, as well as notifying partners and contacts. And then tertiary prevention. Educate caregivers of people with HIV about standard precautions, maintain long-term DOT therapy for tuberculosis, identifying community resources, providing supportive care, as well as setting up support groups for persons with HSV. I mean, those are just some limited things, but you can think of all the wonderful things that, you can do as a community health nurse, and working with these populations. And so, there's all sorts of support groups that can be developed and maintained, to assist them, in, leading as close to normal, healthy lives as possible. Which that leads us to chapter 27. So chapter 27 is violence and human abuse. So violence is a pervasive public health, social as well as a developmental threat. It is the leading cause of death and disability, that disproportionately affects the youth, low-income populations, and people of color. In 2017, suicide was the leading cause of death for persons aged 10 to 14, 15 to 19, and 20 to 24, and homicides ranked third for persons aged 15 to 19 and 20 to 4. So obviously there is pretty significant mortality and morbidity result from violence. So community violence, intimate partner violence, and sexual violence, are the most, and suicide are, the most and severe form of violence. Community violence is violence that occurs between strangers, friends, or acquaintances, and it typically takes place outside of a residual dwelling. It includes physical fighting, assault with or without the use of firearms and other weapons. Your intimate partner violence includes physical, sexual, or physiological harm, including stalking caused by current or former partner or spouse. And sexual violence refers to sexual activity when consent is not obtained or not given freely. And then suicide is, contrast is, of course, your self-directed violence. And so there is actually a division of there's the Division of Violence Prevention within the Centers for Disease Control and Prevention, or the CDC. And so it's a public health approach to violence prevention, and it's a step-by-step approach. So some of the questions, right? Where does the problem begin? How do we prevent it from occurring? Right. So first we want to identify the problem, collect data to obtain the who, what, where, when, how. That's more of your epidemiological approach. We want to look at the risk factors. Why does one person or one community experience violence and another does not? We also want to develop and test prevention strategies, sharing that information, and then of course disseminate and implement the strategies. And so with our Healthy People 2030 goals, for objectives for reducing violence, we want to reduce the number of young adults who report 3 or more adverse childhood experiences. We want to reduce the intimate partner violence, as well as reduce gun carrying among adolescents. And so we know that that's a huge issue. And so the CDC's four-level socio-ecological model is used to aid in understanding the interplay among the individual, the relationship, community, and societal factors. So at each level, there's different factors that increase a person's risk for violence or that can even serve as protective measures. So when we look at the individual, that's the biological and personal history factors that increase the likelihood of a person becoming a victim or a perpetrator of violence, as well as, in addition to the risk factors, others, include education, substance use, a history of abuse, including witnessing abuse, as well as mental health disorder. The second level is the how close social relationships, including those with peers, intimate partners, and family members, increase one's risk for violent victimization and perpetration of violence. And then community, and that's your schools, your workplaces, your neighborhoods, right? It is important to consider if there's a high level of mobility, a low level of cohesiveness and affiliation with neighbors, high population density, few green areas for games or recreation or drug traffic, other things that influence people's and communities' resilience to violence include coordination of resources and support services among community agencies, access to mental health and substance use treatment services, support and connectedness, including to one's community, family, peers, and school. And then the fourth one's your societal. These are things like, does the culture accept violence? Do they, reduce inhibitions against violence? And things that, create and perpetuate disparities between different segments of society, health, economic, education, and social policies that help maintain economic or social inequalities between members of a group. So violence against one individuals or oneself. So homicide is the killing of one human being by another. It is often related to substance use. Most homicides are committed by someone known to the victim and occur during an argument. Violence often precedes homicides within families. And we know that rates of homicide are increasing among adolescents more than any other age group. A large percentage of our homicides are caused by the use of firearms. Another part of family homicide too is that children may witness a murder or find the body of a family member. And so, they're at a greater risk for mental disorder, self-harm, substance abuse, and suicide if they're older than the age of 18. Women are more likely to be killed by an intimate partner than a stranger. And that intimate partner can be a husband, boyfriend, same-sex partner, or ex-partner. Risk factors, previous domestic violence, access to guns, estrangement, threats to kill or threats with a weapon, and a stepchild in the home if the victim is a female. So prevention is, we look, the prevention of family homicide involves working with abusive families. So nurses have a duty to warn family members of the possibility of homicide when severe abuse is present. And so, that is something that we do have to worry about. Assault is a violent physical or verbal attack. And so the greatest risk factor males are more likely than females to be assaulted. Youths are also at a significantly increased risk. The greatest risk factors for an individual's victimization through violence is age. So again, youth. women are more likely to be victimized by a relative, especially a male partner. With sexual violence, um, sexual violence is forcing a person to take part in a sexual act when the person does not consent, and then includes rape, sexual coercion, being made to penetrate a perpetrator, unwanted sexual contact experiences, and unwanted not sexual non-contact experiences. Um, and so rape is, a significant issue that we worry about. It is often unreported. Most incidents of rape are spousal or acquaintances. Females are more likely than males to be raped. Risk is increased in cities between 8 p.m. and 2 a.m. on the weekends and in the summer months. We look at, rape can occur on college campuses as well. And so the White House has established a task force to protect students from sexual assault. And so it is, something that they are taught in, orientation. Prevention of rape requires a community focus for educating both the community as a whole, as well as key groups such as police, healthcare providers, educators, and social workers. So prevention should begin early by promoting healthy, respectful relationships in families so that the children learn that interaction should be based on respect and trust, as well as conflict resolution. That does not include violence. The first step in intervening in the incidents of rape and treatment of rape survivors is to change and clarify misconceptions about rape and victims. Rape is a crime of violence. It is not a crime of passion. So underlying issues of, for rape is hostility, power, and control rather than sexual desire. And people do react to rape differently based on personality, past experiences, background, and support that they receive. Some cry, shout, some will discuss, some others will become reserved and withdrawn and don't want to talk about the rape. They may blame themselves. And so, we don't, if anybody, wants to be a SANE nurse, that is, something that is very specific to that. When working with victims, make sure that we, collect evidence correctly and in a systematic manner. And so again, part of it too is making sure that we are providing the follow-up services when somebody is raped as well. So, um, the trauma that was involved. Some actually, they may develop your PTSD. So making sure that they have that follow-up treatment is key. Human trafficking is another issue that we have to be aware of. Human trafficking is a significant public health issue. It's global. It's an umbrella term that includes activities involved in recruiting, harboring, transporting, or providing an individual for forced services or commercial sex acts through the use of force, deception, or coercion. Human trafficking affects all races, ages, genders. Women and children under the age of 18 are at heightened risk. Children are largely targeted due to their earning potential, with runaway and homeless youth the greatest risk. Depending on where you work, or, when you look at your educational requirements that are required for your license renewal. So for example, for Texas, when I was doing my CEUs for license renewal, one of the mandatory CEUs that I had to do was on human trafficking. Just because of the area, there is a lot of human trafficking that is been discovered within Texas and in that area. So I am not an ER nurse, but that doesn't mean that, other aspects of nursing. You won't come into contact with victims of human trafficking. Most most people that are being trafficked will come into contact with a healthcare provider, whether it's through the emergency department or it could be, in a clinic or somewhere else. But we don't usually, it's hard to identify them. So victims are not going to identify themselves as being a victim. And that's usually just because of the fear that is involved, as well as the distrust of the system, because, again, they may have been in contact with healthcare providers before and nobody has helped them. But again, usually they're going to come in with their trafficker that will identify themselves as a family member or, a support system. It's, the trafficker can be male or female. They, of course, are going to appear supportive and caring. And so, we do have to be careful. So looking at those red flags, right? The family member, the friend doesn't allow the individual to answer the healthcare provider's questions or answers for them. The individual may be, reluctant to describe symptoms or the events leading to the complaint. They were vague in their responses or maybe inconsistencies. They may not be able to provide an address. They may not have any documentation, may not even know where they are. And so, they also may have, when we're providing care, they may have unexplained bruises, burns, lacerations, bite marks, vaginal or anal tearing, STIs, unwanted pregnancies or unintended pregnancies, nutritional deficits, substance use disorder. They're also at risk for depression, PTSD, suicidal ideation, or suicide attempts. So we do need to provide trauma-informed, non-judgmental care. And so the goal of the interaction should be to create a safe place and support empowerment, right? And so there isn't like a screening tool for this, but we do need to be, try to get as much information from them. If we suspect that a victim, that a patient is a victim of human trafficking, we have to engage social workers or a victim advocate. If they're under 18, we need to call Child Protective Services. If we think that the patient's in immediate danger, then we need to call law enforcement. We do have to get, them to trust us as much as possible when we're dealing with them. Suicide is the act or an incident of taking one's own life voluntarily and intentionally. According to the CDC, suicide rates are highest among individuals 45 to 64 years old. Wow. It does affect, all age groups. Females are more likely to attempt suicide. However, males are more likely to complete suicide. Risk factors for suicide include depression or other mental health disorders, substance abuse, having access to a firearm, partner violence, or neglect issues. Other groups that have disproportionate rates of suicide include veterans, other military personnel, workers in construction and the arts, design, entertainment, sports, and media fields. Affluent and educated people often have higher rates of suicide than do economically and educationally disadvantaged. Nurses, the majority of those that have completed suicide have visited a healthcare provider in the prior month. So nurses and healthcare providers need to screen and intervene for those that are at risk. We can be involved in, suicide prevention, as well as taking care of those that have attempted suicide. So we look at family violence and abuse. These are usually the hardest ones to discuss. Family violence includes sexual, emotional, and physical abuse, which can cause, significant injury and death. Types of family violence, we have, violence towards the child. So, infant or child and, shaken baby syndrome, right? It's, mm. It could be toward a spouse or partner, or it could be towards an older adult, or even towards a non-spouse or a non-partner. Um, Child neglect, right? That's the failure to provide physical care like food, shelter, and hygiene, emotional care, and not providing stimulation necessary to achieve their developmental milestones, preventing them from getting an education, or even from receiving necessary, health or dental care. Um, and so, and then intimate partner violence is violence between, like I said, it's, a spouse or a partner, or even a non-partner. Um, so, um, There are risk factors for child abuse. Some of the risk factors for child abuse are the parents employed? Do they have the resources to care for their child? Is there a support network that offers assistance? Do the one or both parents have a history of child abuse? Is the parent or victim or perpetrator of intimate partner violence? Do the parents have knowledge about child development? Do they have problems with substance abuse? Are they overly critical of the child? Um, are the parents communicative with each other and the nurse? Does the mothers of the child seem frightened by her partner? Does the child suffer from recurrent injuries or unexplained illnesses? So some of the, indicators of child abuse, nurses need to recognize the physical and behavioral indicators of child abuse. Abusers, this can be, or the abuse can range anywhere from physical attack to passive neglect. The kids may have physical injuries, cuts, burns, bruises, broken bones. They also may be beaten, burned, kicked, or shaken. Again, they also may be deprived, right? They may have been malnutritioned. The child that's at risk for mistreatment is those that have young parents who lack experience with children and have unrealistic expectations. Those in families that struggle with poverty or unstable housing, divorce or unemployment. Those that have parents who abuse drugs or alcohol, and those with parents who have themselves had childhood trauma, and those with parents who are isolated and do not have a supportive partner, family, or community. Children who are abused or witness domestic abuse can suffer developmentally. Adolescents may run away from home. They may abuse substances. They may become depressed. And so to recognize actual potential child abuse, be alert to, an unexplained injury, a whiplash caused by shaking children, old or recent scars, skin burns, bruising, soft tissue swelling, human bites, recent or healed fractures, subdural hematomas, trauma to the genitalia, dehydration or malnutrition, um, given giving inappropriate food or drugs, evidence of poor general care, including poor hygiene, dirty clothes, unkempt hair, dirty nails. They also may have an unusual fear of the nurse or others and being referred to as a bad child. Physical symptoms of stress from physical, sexual, or emotional abuse can be hyperactivity, withdrawal, overeating, skin conditions, vague physical complaints, exacerbation of stress-related physical problems like asthma, stuttering, enuresis, and caprices. And then when we look at abuse of the older adult, Elder abuse is growing. It is an intentional act or failure to act that causes physical or that causes a risk of harm to an older adult. And an older adult is those that are age 60 or older. So the World Health Organization defines elder abuse as a singular repeated act or lack of appropriate action occurring with any relationship where there's an expectation of trust, which can cause harm or distress to an older person. And so elder abuse, right? It could be physical, it could be emotional, it could be financial, it could just be neglect. Elders may also be abused by, rough handling and posing unrealistic toileting demands, ignoring special needs, giving food that the older person can't chew or swallow, giving medication to induce confusion or drowsiness so that will be less troublesome, right? So the CDC recommends the following actions to prevent elder abuse before it begins. Listen to older adults and their caregivers to understand their challenges and provide support. Report abuse or suspected abuse to Adult Protective Services. Educate yourself and others about ways to recognize and report elder abuse. Learn how the signs of elder abuse differ from the normal aging process. Check in often on adults who may have few friends and family members. Provide overburdened caregivers with support and help from friends, family, or other local care groups, adult daycare programs, counseling, and outlets intended to promote emotional well-being. So what are some things that we can do as nurses when we look at primary, secondary, and tertiary prevention? So primary prevention, we can, teach alternative methods of conflict resolution, anger management, coping strategies, whether, it's in community group or even one-to-one. We can organize parenting classes to promote anticipatory guidance of expected age-appropriate behaviors. That helps to, help them to provide for appropriate parental responses and, appropriate discipline. Educate clients about community resources that are available to provide protection from violence. Promote understanding about the aging process, right? How to ensure a safe and secure environment for older adults in the community. Assist in removing or reducing factors that contribute to stress. Encourage older adults and their families to safeguard their funds. Teach individuals that no one has a right to touch or hurt another person. Make sure that they know how to report cases of abuse. Secondary prevention, identify and screen those at risk for abuse and individuals who are potential abusers. We can assess and evaluate any unexplained bruises or injuries, screen all pregnant women for potential abuse. What else? Refer sexual assault or rape survivors to local emergency departments so that they can be assessed by a sexual assault trauma team. Assess and counsel anyone contemplating suicide or homicide and refer them to the appropriate services. Support educate offenders. Assess and help offenders address and deal with stressors that can be causing or contributing to the abuse. Advocate for legislation designed to assist older adult independents and caregivers and to increase funding for programs that supply services to low income and at-risk individuals. Some of your tertiary preventative measures. We can establish perimeters sources in the community available to survivors of violence. And if the court systems are involved, we can work with parents while the child is out of the home, like if they get put in foster home or foster care. Refer to mental health professionals for long-term assistance, provide grief counseling to families following the death of a family member to suicide or homicide, as well as developing support groups for caregivers and survivors of violence. All right, and that is what I have for these 4 chapters. I will see everybody on Wednesday. Have a great rest of your weekend.